In previous video, we have discussed about visual pathway. Today, let's discuss about visual field defects. But before going into details of visual fields, let's briefly discuss some important points which are necessary for understanding these defects. So first point is examination of visual fields. It can be done crudely by confrontation method if defects are larger. But for smaller defects, they require visual field charting with Goldman perimeter. Now, while interpreting the results, it is important to remember that the ocular system reverses the image. That is, the nasal side of the fundus pick up the temporal image and vice versa. So the damage to nasal side of the hemiretina will produce a temporal visual field defect and vice versa. Another important point is in optic chiasma, the nasal fibers from lower hemiretinae will loop back while crossing to the opposite side. So in most lesions involving posterior most part of optic nerve, these nasal fibers from opposite retina, they are also trapped, producing visual field defect in contralateral eye as well. Now the visual information from the left visual field in each eye is projected to the right visual cortex and vice versa. And the superior visual field is projected into the inferior half of primary visual cortex and vice versa. And the most central visual field or macular zone is projected most posteriorly at the occipital pole, whereas the peripheral field is located anteriorly within primary visual cortex, as seen in the image here. Another important point is the macular regions of the cortex, they have a double vascular supply from the middle cerebral artery and the posterior cerebral artery. So if there is disruption of any one vascular supply, like in case of PCA or MCA stroke, there is still another blood supply that the macular portion of the visual cortex can rely upon. In such cases, the person's vision in the peripheral area is lost due to the resulting infarct, whereas the vision in the center of visual field, or we can say macular zone, is preserved. This phenomena is called macular spuring. Now let's start visual field defects. So loss of vision in one visual field is known as anopia. Loss of vision in one half of visual field is known as hemianopia, whereas loss of vision in one of the quarters of visual field is known as quadrant anopia. Occasionally, blind spots are found in portions of field of vision other than the optic disc area. Such blind spots are called scotoma. Now let's discuss these defects in detail one by one. Let's begin with anopia. So anopia may be right anopia or left anopia. Lesion of right optic nerve causes right anopia, whereas if the lesion is in the left optic nerve, it causes left anopia. Involvement of both optic nerve causes total blindness. Now let's come to hemianopia. It may be homonymous hemianopia if hemianopic visual field loss is on the same side in both eyes, or it may be heteronymous hemianopia if hemianopic visual field loss is on the opposite side in both eyes, or it may be altitudinal if upper or lower half of the visual field is affected. In case of homonymous hemianopia, it may be right homonymous hemianopia or left homonymous hemianopia. It usually occurs if there is lesion in optic tract. Now each optic tract denervates the corresponding half of each retina on the same side as the lesion. As a result, both eyes loses sight in opposite half of their visual fields. For example, the lesion of right optic tract denervates right half of both retinae, thereby losing sight in left half of their visual fields, resulting in left homonymous hemianopia. These patients, they frequently complain of bumping into obstacles on the side of the field loss, thereby bruising their arms and legs. Now coming to heteronymous hemianopia, it may be binasal heteronymous hemianopia or bitemporal heteronymous hemianopia. In case of binasal heteronymous hemianopia, there will be loss of fields surrounding the nose. It occurs due to dilated third ventricle, which forces the angle of chiasma against carotid arteries. It may also occur due to dilatation of carotid arteries on both sides, thereby compressing the lateral uncrossed fibers in chiasma from both sides. In case of bitemporal heteronymous hemianopia, there will be loss of fields closest to the temples. Compression of nasal fibers, that is crossed fibers in the optic chiasma, by pituitary tumor, it causes bitemporal heteronymous hemianopia. Now next is altitudinal hemianopia. It may be upper altitudinal hemianopia or lower altitudinal hemianopia, and it may be unilateral or bilateral. This defect is typically seen in ischemic optic neuropathies. Severe hypotension, sudden hemorrhage, and rapid development of anemia may be responsible for simultaneous bilateral ischemic optic neuropathies with altitudinal visual field defects. They may also be due to bilateral symmetric involvement at a cortical level, including bilateral lesions affecting the occipital lobe. In case of upper altitudinal hemianopia, the person will be able to see animals walking but has difficulty seeing the birds flying. Whereas in case of lower altitudinal hemianopia, the person can see birds flying, whereas he has difficulty seeing the animals walking. Next, coming to quadrant anopia, it may be homonymous quadrant anopia involving the same side of visual field in each eye, and either superior or inferior quadrants. Or it may be heteronymous quadrant anopia involving opposite sides of visual field in each eye and either superior or inferior quadrants. Now coming to homonymous quadrant anopia, it may be left superior homonymous quadrant anopia, or it may be left inferior homonymous quadrant anopia with or without macular spuring, as shown in the images here. Other varieties of homonymous quadrant anopia may be right superior homonymous quadrant anopia or right inferior homonymous quadrant anopia with or without macular spuring, again as shown in the images here. Whereas in case of heteronymous quadrant anopia, it may be binasal superior quadrant anopia or binasal inferior quadrant anopia, as shown in the images below. Or it may be bitemporal superior quadrant anopia or bitemporal inferior quadrant anopia, again as shown in the images below. Quadrant anopias, they may be produced by temporal, parietal or occipital lobe lesions or lesions in optic radiations. Now let's come to scotoma. Scotomas can be classified either based on position or based on their shape. Based on position, it may be central if it involves only fixation, or it may be paracentral if it involves an area of visual field away from fixation and tends to be elongated circumferentially along the course of the optic nerve fibers within the central 30 degrees. Or it may be secocentral if it extends from fixation to the blind spot. A central scotoma typically occurs in optic neuritis, whereas paracentral scotoma may be seen in glaucoma or lesions affecting the optic disc, such as papilledema. A secocentral scotoma is usually caused by disease of papillomacular bundle or intrinsic optic nerve tumors. Now, based on shape, scotoma can be classified as ring scotoma if it produces annular visual field defects centered on fixation, or it may be arcuate scotoma if it produces an arc-shaped defect of vision arising in an area near the blind spot and extending towards it. Ring scotoma is typically seen in age-related macular degeneration, whereas arcuate scotoma, it is typically seen in glaucoma. So that's all for today. Thank you. Have a nice day.